That has been my account balance for the last, I think, 2 weeks or more. Sikukuwa na option. Sasa ningefanya nini? I didn't have any other way. So nataka nilale nje. Na ikiweka BSR. Badala achukue nini? FT.
Just to me. If you have a bank, sorry, don't go to the intentionally. You don't want intentionally. Then one thing that we can do. So they have a different Evil. Now, for them, yeah. Yako nishatoa. Hizi zingine zimependa macho. So,
I will introduce the speakers that we have, and each of them is going to give a presentation of about 15-20 minutes. So it's my pleasure to start by introducing Professor Charles Nzioka from the Department of Sociology and Social Work at the University of Nairobi. He's a professor in sociology, PhD from University of London, Goldsmith College, initial BA from University of Nairobi, and he'll be talking to us about the role of social sciences. And then he will be followed by Professor C.F. Otieno from the School of Medicine, Department of Medicine and Therapeutics. I'm sure many of you are familiar with Professor Otieno. So he's a diabetologist, so he'll talk a little bit about multimorbidity and NCD multimorbidity and COVID. And then the third speaker will be Dr. Anne Kamau, who is the director of the ARUA NCD Alliance. She's based at the Institute of Development Studies, and she'll just tell us a little bit about what the network is about and what it aims to do. And then we'll welcome questions and comments thereafter. So it's my pleasure, first of all, to introduce Professor Nzioka to give the presentation, and then we will move on from there. So, Prof, thank you very much.
Thank you very much, Dr. Aya. I need some assistance in terms of, I need to share my presentation. Yes. I hope you can now see my presentation, right?
Yes, we can.
Thank you so much.
If you can just put it in the presentation mode, we're good. Yeah, thanks.
Is that okay?
Yes, we're good. Yeah.
Okay. Thank you so much, Dr. Aya, for inviting me to talk about the role of social sciences in the COVID-19 pandemic response. The title of my paper or my presentation today is Social Sciences, the Social Vaccine to the COVID-19 Pandemic, some reflections from Kenya. I have borrowed the word social vaccine from Professor Kelly, who used to work together sometime when I was in UNESCO, and he used to regard education as social vaccine against HIV. So it's just a coinage, and therefore you'll understand it's a borrowed concept. So what I want to do, my presentation now, look at the trends of HIV in the country. I'll look at what are the prescriptions from the WHO and the Ministry of Health. I'll look at why COVID is on the increase in Kenya. And then I'll end up looking at the possible role of social sciences in the COVID response. So let's just start with the introduction. I think we all agree. I won't go into the nitty-gritties of what is COVID because I think that is too rudimentary for people of your level. So COVID-19 has really caused devastation in our economies and profound changes in our lives. The epidemiology of COVID-19 is not uniform across the world. There are significant variations across the board, and largely because of social demographic profiles, which differ from area to area. For example, in Europe, you have a fairly aged population. In the African setting, probably we have younger people. And that might explain some variations, but they are deeper concerns. You know. But the impact has mainly been closures of businesses, loss of jobs and employment, forced isolation, reduction of freedom of movement, closure of educational institutions, and general disruption of the social order which existed in the pre-COVID. Now, I'm just giving you some pictures to show you, this is a congestion at a border post, because the truck drivers could not be allowed before they take the COVID tests. We also see new forms of romance, for example. Forgive me for using the word romance, this kind of kissing when you are also having a mask. I find it very interesting. But let's look at COVID-19 pandemic in Kenya. The first case of COVID-19 was identified on March 13th, 2020 in a traveler who had arrived in Kenya from London. And subsequent to that, we have had significant changes, some legislative, others bordering on guidance from government. Schools were subsequently closed on 15th of March. On 25th of March, quickly the international flights were suspended and mandatory quarantine on incoming residents was imposed. So you came from the airport and you went to a quarantine of some kind, and it was imposed on you and enforced. There has also been other measures, including closures of bars, restriction of restaurant operating times, ban on gatherings, barriers, etc., etc. And on the 5th of April 2020, the government declared wearing masks are mandatory in any public place. But since then, there has been a raft of containment measures which have since been put in place, including the imposition of a nationwide curfew, which is still in force from 10 p.m. to 5 in the morning. Now, currently, Kenya is dealing with what I might term, that these are my own creation, the second wave of the COVID pandemic. The first wave started in March and climaxed around June. Then there was a lull period or a decrease between August and October. And then from October, we see another spike, an increase in cases. And it still spirals and abated up to now. So it is still peaking and the trend is on upwards. And therefore the leveling of the curve doesn't look like it's coming anytime soon. Now, as of December 22nd, which is probably today or yesterday, yesterday, some 83,000 cases of COVID had been reported with 55,000 recoveries and approximately 1,500 deaths. Now, what are the prescriptions which we have been told? These are the prescriptions, following Ministry of Health, the protocols and WHO protocols. And we are told to wash our hands frequently with soap and water or sanitize with alcohol-based detergents of some kind. We are told to avoid touching faces, particularly eyes, mouth, and nose. We are supposed to stay as much as possible at home and even sleep a little longer to boost our immune system, to avoid crowded places and gathering, to avoid non-essential travel and shopping, and to keep a distance of about 1.5 meters minimum between yourself and other people. Now, these interventions against COVID are mere prescriptions, and they are modeled on the health education models. But they are based on a range of theories and assumptions. One is the stimulus response theory. The other one is the rational choice theory. The other one could be the theory of reasoned action. In other words, there's an assumption that once people have the information, they will take adequate precautionary measures. And this model, however, addresses what I may call the COVID, the disease, rather than the COVID, the illness. The disease is ontological, it can be established, it is verifiable, it is biological, it is based on the theory of disease, and it can be addressed through those prescriptions, and it can really be managed. But we have COVID, the illness, which is the subjective social component, which depends on people's feelings and experiences to a large extent. And no wonder cases of COVID are still on the increase, because we probably have not dealt with the COVID, the illness, which is the issue. I'll deal with that later. Now, so why is COVID still spreading fast in Kenya? I've tried to look at some, I'm not trying to pretend I'm exhaustive, but I'm trying to look at the range of factors that appear to be from the literature that I've scanned through, and also from my own empirical and observations, and a bit of anecdotal evidence here and there. One is limited knowledge and awareness of COVID. And to a large extent, you still get arguments that COVID is a hoax, doesn't exist, or, So they still persist to those arguments. But more importantly, we have social stigma, which is too intense. Those who contract the COVID, you notice they are unceremoniously quarantined and isolated. Even in death, they are perceived as a huge risk and must be placed in polythene bags, sealed gunny bags, and buried in the middle of the night by some strangers wearing scary masks and protective gears. And the burial attendance is limited and sometimes controlled by state actors. A total intervention of, which goes deep into the family system. And you can see this, I'm just presenting some pictures as an illustration of the fear, the phobia, the opprobrium that we are going through because of HIV. I mean, because of COVID. Burials in the thick of the night. And the people are buried either very late in the night or sometimes very early in the morning. So by the time people get to burials, they would think it's over. And even when you are available, you watch from a distance because you are not supposed to come to the body. So that is deep-seated cultural values and beliefs. For example, beliefs related to circumcision. The other day we saw some section of the community defying the government so that they could conduct the circumcision rituals, etc., etc. There's also the high cost of testing. In Kenya, my simple estimate and the available evidence suggests that we have, we are being charged between 2,000 Kenya shillings to 13,500, which is equivalent to $20 to $150, depending on the facility. And you may need to notice that the NHIF hospital, the National Hospital Insurance Fund, which covers most people in the public sector, and most insurance companies do not cover the cost of testing. And therefore, this limits the scope of testing. And which means that there are people who are still spreading the virus even unknowingly. And even if they wanted, probably they could not afford it. Because you need to look at this cost against the minimum wages, and you could also invite the element of the poverty lines and see how it relates, how they relate. The fifth thing is social inequalities and economic marginalization of large segments of population. And this can be manifested in congested housing and overcrowding public places, particular markets, which means therefore protection becomes a bit difficult because even if you run away from the market by protecting yourself, you still go to a congested homestead, using public transport, which is also congested. And sometimes this makes making social distance impossible. And then you go to these places which also do not have, particularly informal settlements where water is not in abundance. And what you then have is you are required in the prescriptions to wash your hands, and that becomes impossible because there is no hand in the first place. There is no water in the first place. And here I'm just trying to show congestion in informal settlement, and sometimes even in schools. We have open schools. I don't wonder how much water we have. I wonder whether we have. We tried the other day to develop to have desks. So that there can be spacing. But how this translates into reality is another matter, because even when you have the desks, probably you don't even have the classrooms. Now, this is a typical open market, open closed market setting. And the question is, where is the self-protection here? You know, where is the social distancing? And how can you be safe in such an environment? Now look at the transport sector, and I'm talking about social distancing. Can you see any social distancing? Are these people really distancing themselves from anything? And are these not the realities of our people's lives every day? Then we have lack or weak social protection mechanisms to cushion the poor and economically disadvantaged members, particularly the jobless, unemployed, the persons with disability, and the aged. How many of us have some form of protection so much that at the end of the day, when you are unemployed, you can sit in your house and access a meal? Because inevitably what this means, then you have to travel to work, you have to, regardless of the environment you are going to be in. So you start by traveling in a risky environment, using risk means, and you go even to a risk working environment where probably there is no sanitation facility, there are not so many other, there is no water, and that in itself puts you at risk. Then we have comorbidities. Segments of the population, particularly the old, have underlying conditions such as heart failures, coronary heart diseases, diabetes, kidney, obesity, sickle cell diseases, and others even have HIV, and therefore their systems are compromised. And therefore, COVID comes as an additional burden, which then drags the camel's back. Then we have lack of access to quality and affordable masks, which particularly among the poor. Of course, they look like, initially they were exorbitant and far out beyond their reach, but people can afford a bit of them, but not entirely. The question is, what is the quality of these masks? The other element is lack of access to protective equipment, and this has become particularly a thorny issue among healthcare providers, and we are seeing a continued increase in mortality among health workers, and largely because the quality of the same facilities, even access is also limited of the PPEs. Then we have lack of sufficient health systems and public capacities for detection, testing, isolation, and quarantine. And we all know about, in Kenya, you know about the national government concerns. How many beds do we have? Sorry about that. So how many beds do we have? Isolation wards, how many do we have? We have enough facilities, assuming the spiral of this, the spike of infections continues. We have, even at the county level, they have been talking of about 300 beds per every government, county government, assuming that all counties have equal populations. But to what extent is this feasible? Because some of the county governments have been unable to have that. Then we are also talking of demotivated healthcare workers due to lack of insurance. Most of them are not insured. Then there are delayed salaries, on payment of risk allowances, and we are constantly being treated persistent strikes of health personnel in virtually all, everywhere in the country, and every day it is the news, Then we have lack of protective. Now we move to the workplace. We also have lack of preventive or protective systems and the programs in most workplaces. How often do we fumigate the places? Do we have any sanitizers on a consistent level or not? You know, and finally, we probably have a growing fatigue with the COVID, and the people have let their guards loose because we have been having COVID-19 now for probably close to 9 months, and when the people get tuned to one thing at one point in time, then they become fatigued and they almost say they become fatalistic in a way that let it be what it must be. Now, let's come to the critical case, which was or the thrust of this paper, which was how can we social sciences inform COVID-19 response? Now, I quote from Dr. Rachel Midumas, a research impact manager at the London School of Economics, and she says, and I quote, extenso, science has been central in informing policy in the response to COVID, but ensuring the successful implementation of these policies and the direction of a long-term recovery is the role of social sciences, and that's why I've underlined that. It is the role of sciences, social sciences, to ensure successful implementation of these policies, the directions, the long term. But generally, what are the major causes of how is our health determined? It is determined at various levels. You can begin at the micro level, meso level, and you can go all the way up to the macro level. But basically, it will relate to national policies and the legislation. How to what extent are we in compliance with the protocols and guidelines? The other thing would be the shared community factors. And here you are looking at social relationships, cultures, religious beliefs, etc., because they are all shared. Every community, most communities have their own cultures, even the artificial ones, which have recently been created. They still develop their own social understandings. Then there's the institutions, institutional rules, regulations, guidelines, ethos, etc., etc. Then we have intrapersonal group, let's say like a family, dyadic relationships, group influences, social network, peer pressure, etc., etc. And then we have, no, that is intra. Sorry, I need to correct that. The first one, is inter. Then we have the last one, which should be intrapersonal. And these are individual factors. How do we perceive risks? What are our attitudes towards certain things as individuals? And this is not mine, it's adapted from some source. But let us move and look how can social sciences then inform the COVID response. One, social science is fundamental to understanding and making the best of us, or of the world around us. Social sciences help us to understand, to create, to engage more meaningfully from an emic approach. Emic approach is, there are two approaches. There is the ethic approach and the emic approach. The emic approach is where the ethic approach is where you study society from outside. The emic approach is where you approach things from the inside. So they allow us to get closer to people's lives and to know what shapes their actions towards certain things and what shapes their attitudes or their beliefs in certain things. The second thing is social science through research can provide empirical context-specific evidence on the drivers of COVID, leading to more effective and sustainable context-specific solutions. The other thing is that social science research can provide a better understanding of human behavior and societal behavior in general, which is vital in developing strategies. Probably I'm phrasing this. For example, you may need behavioral psychologists who may be able to tell you why people, what are people's desires, how do we address risks, and how do we even deal with these issues of emerging resistance to I was just to COVID protection. I was just looking at a cartoon which was sent to me a few days ago. And people were wondering whether they are going to be putting on masks to avoid police or to self-protect. You know? Because people are probably more scared of the police than they are scared of COVID. The other thing is social scientists can help policymakers and natural scientists. And natural scientists, I know I'm talking to an audience of medics, you know, you can call yourself natural scientists. I know you're not, you are medical, but we categorize when we draw the divide between social and then natural sciences, you know. That's how I'm grouping that, and that's why I'm putting it in quotes. In developing solutions that are able, people are able and willing to follow. For example, what is the point of devising lockdowns that nobody will follow? How often have we followed these lockdowns? Because for some, we had the containment measures which belong lockdowns of Nairobi, Mombasa, but people still went around their business, circumventing the law, and sometimes passing through what so-called panya routes or, you know, illegal routes. What is also the point of developing a vaccine that nobody will take? So to get these answers, you need input from social scientists. Social scientists also tap into indigenous knowledge systems so that they can build up culturally sensitive and acceptable innovative strategies for dealing with the non-communicable diseases, including COVID. But remember, pandemics are not new and they have occurred in history. I know, you know, you can go back to history every other 100 years. In 1920 we had, in 1820 there was, and you can continue. But there are also others, you know, and I found this very interesting because, like, one of the prescriptions is that people should isolate, quarantine themselves. And if you go to the Bible, which I'm a little aware of, I don't know much about the Quran and other religious beliefs, you'll find that quarantine is in the Bible. And Isaiah 26:20 says, "Go home, my people, and lock your doors, hide yourselves for a little while, or until the Lord's anger has passed." You know, so there are many things we can tap in indigenous knowledge. I'm counting this as indigenous knowledge, but it's a bit superficial. You know, probably we need to go a little more deeper than that. So social sciences can assist policymakers again to understand the impact of current interventions and even sometimes plan future policy to mitigate unintended consequences. For example, we have had the increased childhood pregnancy, childhood, but pregnancies among young children due to closures of schools. And we also have a phenomena of teenage parents, girls and boys are becoming parents, so that when a parent is complaining, the other one is also complaining. Impregnated my girl, sometimes they argue even the girl was older than my boy, and that brings a complication. Then there's also the development of new career and livelihoods due to lots of jobs. When people are out of jobs for many years, what do they do, you know, and what other becomes of them? So we can look for answers from social scientists. But let me summarize in a way and very quickly. What is the role of social sciences in the COVID response? I can summarize it as it can help in understanding processes through which social, behavioral, economic, and environmental factors influence transmission of COVID. The second, they can also help discover mechanisms which can tamper, interrupt, accentuate, or modify these transmissions. They can also help develop interventions which harness this mechanism to improve public health and to reduce the spread. They can also, social sciences can help in evaluating interventions because we have tried many interventions, but how many of us know how effective these interventions and politics are? And it is basically the role of social scientists to be able to identify what are the weaknesses in this so that we can stop the spread of COVID. And finally, they can help to influence policy and practices by communicating results and implications of research to policy, to policy people, policy makers, to professionals, and even sometimes to lay audiences, because social scientists can be able to scale their understanding down to a level where they can be able to talk to lay people. So I think that is about what I have to say for today. Thank you very much, Mr. Chairman.
Yeah, thank you very much, Professor Nzioka, for that. I think that's been a very refreshing discussion of the role of social science in the COVID response, because a lot of times we tend to really focus, as you've said, on the disease and not the illness. There is a couple of hands up just before we'll take a few minutes of some questions, and there is one question on the chat. Professor Nzioka, maybe you can just talk a little bit about that. It's about low socioeconomic status. And the question is that whereas the people in low socioeconomic status appear to be at higher risk, the local data suggests that the higher socioeconomic status are the ones getting COVID. Are we not testing them? Maybe you can just comment on that. And then if you have other questions, I'll ask Prof. Omo-Wanzala as well, just after that. Prof. Nzioka?
Thank you very much, Dr. Aya. I think these are just ideas. We need a little more empirical evidence. What I know is there is much visibility of the upper class. When they get affected, they get media attention, they get the press, everybody writes about them, they participate in the social media, and they discuss these things. But the low socioeconomic classes hardly feature. And one of the problems is nobody tests them. So they will tell you that I had malaria, I had these kind of things. And because they hardly discover, and I think this illness is coming and disappearing sometimes without people getting to know. So there's more visibility. What you are seeing is, my position is, there's more visibility of the upper class because they have access and control of media and attention. The lower class, nobody knows even what they are suffering from. And even if they became unwell, so what? They have always been unwell because of eating bad foods and those kind of things. And therefore, that is my position. I think the vulnerable, the poor, the marginalized are more prone. Even the kind of testing we have been conducting, how much of it is done in the slum areas? How comprehensive is it to a level where we can uncover the extent and magnitude of this pandemic in these populations? That's my view.
Thank you for that. Okay. Prof. Omo-Wanzala, you had a question?
Yes, can you hear me?
Yes, we can.
Yes, yeah, this is a good talk, although I came in a bit later, just to understand, the role of social science. And that's really what we have been attempting to do and attempting to understand. I would like to ask this, we are creatures of habit. And we develop habit depending on culture and how we grow up. So how do we communicate risk? That's what I really want to hear. How do we communicate risk? For example, when you get into a car, put on a belt, drink boiled water, wear a mask. Professor Nzioka, how do we communicate that so that it will appeal to the individual, so that the individual stops fearing the police, but begin to look at themselves as people are at risk, and that this communication is actually good. How do you communicate? And that's where, for me, sitting on the task force, that has been my challenge. How do I communicate risk, culturally or otherwise? So I would like to hear your thoughts of how we can do that. And then on the question of middle class or low class, COVID is everywhere. And in fact, now we are seeing that the private hospitals seem to have more patients than the public hospitals at this point in time, which might be telling us a different story. But Prof, thank you for the talk, but can you let's go through this course of how do we really communicate risk, knowing that we are creatures of habit. Over.
Thank you very much. Can I respond?
Yes, please. Yeah.
Now, let's start with the first one, which is risk. How do we communicate risk? Risk, there are two models, and I think I made a statement. I said, we are having a problem of, not of COVID, the disease, but COVID, the illness. For you to be able to communicate, most of our planners approach this matter from the rational approach, the health belief models, which are based on rationality. It's like telling somebody there is a lion across the road. There are some journeys, then you take precautionary measures. But even when you tell people that there is a lion across, and when you open your window or something, it will catch you. Some will even go to check whether it is a male or a female, it is small or it is big. Why? Because the language of communication must resonate with the context in which these people live. And they must be able to relate the risk to their own lives. To the extent that you do not test them and they do not know of any person because they cannot access, the cost of testing is prohibitive, then to them, either it is a hoax or it is a disease of other people. And therefore they invoke the theory of difference. The theory of difference works in this way, that any person who is different from me is the one to get it. Is either because it is the disease of the rich. After all, those are the people we hear about on TV and on radio and on all those kind of things. So language is important. They must be talked to in a language that they can relate to. But more importantly, they must be able to relate either with the disease in person so that they know of somebody who is suffering from it, or they should be able to relate with somebody who is similar or shares similar characteristics to them, or it must be expressed in culturally relevant. So it could be either class relevance or culturally relevant language. But when you talk about COVID, and all they can see is in the media, and then suddenly some big people have got it, and then because nobody tests them and tells them you have it, and they probably have just been having mortality out of other diseases, which are at equal levels, then they have no way of being able to identify with your interventions. And that is where we are going to have a problem. So you move from COVID, the disease, because the disease is very clear on what it is. It is droplets which are transmitted through the respiratory systems, and you need to keep the distance. To the fact that now this is a disease which relates to your people and has affected so and so, and it is manifested this way. I think that is my answer.
Okay, thank you very
The
much.
second other thing is there was a question of the middle class. I do agree again that there's an avalanche, into public, private hospitals. But again, I think one has to look at the general health infrastructure in the country and to look at the confidence levels people now have in the public against private. If every day we are treated to scenarios of contestations and arguments and strikes and all those kind of hullaballoos, how many people would have then? You see then people moving to the extent that they are able to afford to the public, to the private institutions of healthcare. And that in itself then creates what should not have been there, it creates congestion in these hospitals, which could have been avoided if we had restored confidence in our public health systems. Now, as to the middle class, I still maintain that the key to middle class, even if you were to look at it from a demographic point of view and in terms of proportions, the middle class comprises a very small proportion of the total population, at all times not exceeding maybe 10%. But they have more visibility because they control all those instruments that make them visible. And therefore, anything occurring to them will be more pronounced than what occurs among the lower cadre. Thank you.
Thank you, Prof. I think we'll just take last couple of comments. We'll try and combine them so I can then invite Professor CF to give us his presentation. So on the Q&A, there's a question about careers, the emergence of new careers. And then there is also something about the hoax impact. Could you maybe just make some brief comments on those two? There's also another comment about traveling in and out. Maybe you can hold that until after the second presentation. Maybe just comment on those two.
Thank you so much.
Yeah.
Now, the emergence of careers, we are basically what I'm talking about is there are some new dimensions which are coming up. You know, not all of them are negative. We were just having a conversation with a few colleagues of mine, and they were telling me how suddenly now we can hold meetings, many of us from our houses, and that was not possible. And nothing has come new, you know, in the recent months. It's only that these systems existed, but we were never bothered about them. Now, with the emergence of COVID, we are going to have things which were not expected, and I've just given examples of the teenage, parenthood, and there will be career changes because people have to change their careers. If you are a teacher, the school has closed for so many, and you have seen it, you know, even in the media, where schools are closing and people are now either selling mangoes in the schools or doing other things in the schools or making them stores of anything. Now, has anybody bothered to look at this dimension? What is it likely to lead to? Are we going to have a new crop of forced entrepreneurs, or are we just going to have other people changing careers or anything? Because sometimes crises like this also lead to some other positive things, and that is what I was alluding to in my presentation. I was saying there are many other things which were unexpected. There are many other alterations in our social systems which will occur because of this. Some will be short-term, medium-term, and others will be long-term. But in any event, they will significantly alter our ways of thinking, our economy, our patterns of interactions, etc. For example, do you need now to go to New York every time there's a meeting, or you can have a meeting and attend it? Can you teach in, when you're in London and you're teaching Nairobi and vice versa? You know, there will be many things, dynamics, which social scientists could step in and document. That's the point. Thank you.
Thank you very much, Professor Charles Nzioka, Professor of Sociology, Department of Sociology and Social Work, University of Nairobi. I would like to invite Professor CF Otieno from the Department of Medicine to now give his presentation. Please continue to post your questions on the Q&A. Some of them will be answered on the chat, and then we'll have another round of questions and comments after the two presentations that follow. Thank you. So Professor CF.
Can I pull down this presentation?
Yes, please. Yeah.
Thank you.
So Professor CF Otieno, the floor is yours, or the screen. Sorry, we're having problems with the Prof. CF and the presentation. You just give us a moment just to sort it out. So okay, that's Prof. Nzioka, okay.
Dr. Aya, Prof could share with us and we can.
Yeah, he's trying to, because it
Yes.
said he sent the presentation.
Yes.
Yeah.
Has he
so
sent to us? Because
I emailed you a little earlier. We had emailed you a little earlier.
Dr. Aya, Prof CF, we have
Yes.
put the slides. Yes.
Yeah, good, thank you. So I think this is what Prof. Nzioka was talking about, new careers that are needed. Huh? So, Prof. Otieno, the floor is yours.
Dr. Aya, then probably you could have the introduction part, then I can.
Yes, that's what I'm trying to get.
Yes.
Yeah. So Dr. Ann Kamau, as we sort out the sound bit. Okay. So Dr. Kamau, you can go ahead.
Sorry, Richard, let me share. Sorry, I was on mute. Let me just share. You can hear me?
Yes, we can hear you clearly now. So
thank you. Sorry about that. I was on mute.
Yeah,
let me present the African Research Universities Alliance, the Center of Excellence for Non-Communicable Diseases. And let me just say that this is a new Center of Excellence, which is hosted by the University of Nairobi. And I'm going to give you a little bit more details. My name is Ann Kamau, and I'm based, like what Richard said earlier, at the Institute for Development Studies, University of Nairobi. I'm a medical sociologist, also trained in public health. At the university, I teach health and development. And also I focus more on socio-cultural dimensions of health as in my career. Now, the research, the Center of Excellence, as I said, is new. Started this year, starting from 1st of April 2020. And we are running the center initially for 3 years with a possible extension of an additional 3 years. And this is really a privilege for us to be able to present the center in this one of the first seminar for us. Now, the COE, or what we also call in abbreviation, if you find it, is the NCD, which is the African ARUA Center of Excellence for Non-Communicable Diseases, COE, is one of the 13 centers of excellence within the ARUA network. ARUA is the secretariat is in Ghana, and it has a number of centers of excellence, which might also be of interest to some of us. One is on climate and development. The other one is on inequalities research. I know University of Nairobi is in this one, and even the one on climate change, climate and development. Energy is another one, good governance. Migration and mobility. I think also UN is also on the one on migration and mobility, food security. Then we also have post-conflict societies. We have employment and skills development, urbanization and habitable cities, and water. Those are 13 centers of excellence, including ours. And in addition, this year, the Secretariat has also established 3 vaccine development research hubs, one for the Western African region, Eastern African region, and Southern African region. And I would also say, even though I don't have much information about these hubs, is that the Eastern African one is hosted in Makerere, and University of Nairobi, again, is a member. And I believe some of the members are here. So this is a framework of the centers of excellence. So there are 13 of them, and you can visit the ARUA website just to get more information about each of the centers and even the vaccine hubs, development hub. Now for our center, which is the NCD, which is the Center of Excellence for Non-Communicable Diseases, is made up of 5 research-intensive African universities. And in the middle, you see the University of Nairobi because it is a host or the hub of the center, and we use what we call a hub and spokes model. So the other universities are the University of Ghana in Ghana, Makerere University in Uganda, University of Ibadan in Nigeria, and University of Witwatersrand in South Africa. So all of these have country leads who also in a way, also reach out to other universities within their countries. Now, in addition, we have two formerly now UK partner universities whom already we are engaging with. That is the University of Glasgow and the University of Leicester, both in the UK. And also we've initiated collaboration with the University of Leeds, which again is promising and is something we are working on. And we are continuing to grow these partnerships. A number of universities have contacted us across Africa and even outside of Africa. But so far we have this almost formal, University of Leeds is almost formal. And then we have the other two which are already formal.
Out of time.
Richard? Richard?
Yes, Anne.
May I continue? Okay, fine.
Yes, continue, yes, thank you.
Thank you. So our primary goal as a center of excellence is to conduct research, build capacity, and disseminate findings to address rising problem of NCDs in sub-Saharan Africa and the region. As we know, NCDs is now a major challenge, health challenge. It's really one of the, comprises one of the heaviest disease burden across Africa and of course in other regions beyond Africa. And even with COVID-19, we've seen the connection between NCDs and the COVID-19 disease. So it is an area of interest and it is broad. It's really beyond just the basic disease presentation, disease conditions, but more than this. So based on this, then our key, we have quite a number of goals and objectives, but the key ones for us as an ACE is to provide a platform for creation of long-term strategic network of researchers in African universities to strengthen inter-African collaboration and also collaboration with UK partner universities. And both also in the academia, the research institutes and the private sector. So this is really, we intend to grow the network and we hope that network members can continue, people who are interested can join the network and even initiate their own collaborations with the support of the center. Also, we intend to build capacity within the COE universities, the 5 of them and more, and also the rest, what we are considered as research intensive universities in Africa. And so we hope again, within the 3 years, we should have reached a number of universities who then become members or partners of the COE and whose capacity even to develop their own research proposals is developed, including, but mainly also focusing on young scholars, young researchers, because again, we hope to really be able to bring on board quite a number of young professionals in the program. Now, at the moment, the center continues to make grant applications. At the moment, we have a grant award, which is the ARUA UK Research and Innovation Global Challenges Research Fund grant. And this grant is a 3-year grant initially, which is to help us to build partnership, to support the partnership program for capacity building. And this already we started in April 2021. And we are basically aiming at building capacity across different aspects. And this is our first grant. And again, like I mentioned, we continue to apply for grants. And we also encourage individuals and partners who may want to join our partnership, even in the grant application process, to also make contact with us. We'd be happy to engage with them. So in this grant, we are supporting some minimal studies, but also capacity building initiatives. And we have key thematic areas in our, as our core of the AC in general. And from time to time, we may focus on any one of them. So this might include, and all the details are not all fully here. We'll find more details on our website. We have the prevention aspects as a thematic area, focusing on issues of nutrition, mental health, especially among the young people and adolescents. We know this is a major concern now. NCDs, hypertension, substance abuse, policy and development and communication issues, all under prevention, but of course, even this is more than what is described here. Then we also have a thematic area on morbidity, which again, what CF is going to be talking to us about. And again, here we look at the existence of more than one NCD in an individual at the same time. So again, this is an area that we're focusing on keenly. And we'll be looking at in this, or we'll be hoping to build capacity on in our NCD Center of Excellence. So again, we also look at coexistence and interaction between NCDs and infectious diseases. And also, quite importantly, as also already mentioned by Professor Nzioka, on social determinants of health as in relation to morbidity and pathways of disease progression. So we're going to look at all of these aspects. So it's quite broad in terms of our coverage. And this is why we also really hope that we can build our network so that a lot more people can focus on any of these elements that we raise here, if this is an area of their interest. The other three areas have to do with mechanistics of disease, issues of biobanking and biomarkers, focusing on NCDs like cancer, cardiovascular diseases, and chronic respiratory diseases, among others. Again, if you look at the description from website, it's broader than this. But again, this is also a key thematic area of focus. Then models of care, which Richard is quite passionate about. Also looking at issues of prevention included in these models of care, management and control of NCDs, the care models and that are specific to Africa. So again, this is another key thematic area. So anyone interested on models of care would be quite happy if you would get in touch with us. Again, biodata for evidence-based decision-making. And again, this has to do looking at data and trend analysis for risk factors. And here we hope to use a life course perspective or approach where we can look at disease patterns across the various population groups, whether it's cohorts or this again. And all of these thematic areas, we don't necessarily do all of this within the University of Nairobi, but across the 5 partner universities. You might find one university leading prevention, another one leading morbidity, another one leading mechanics of disease, models of care or biodata. But however, we have in each university, we have a key lead for each of them of these themes. That is also, so within the University of Nairobi, we also have key contact leads for each one of these thematic areas. So kindly would be happy if you would feel free to get in touch with us. So in terms of what we've been able to achieve so far since the 1st April of 2020, and of course, taking note of course that we've had challenges with the COVID-19, we've nonetheless been able to achieve quite a bit. Of course, first by establishing the Center of Excellence, which is more of administrative and internal issue, also working with the 5 partner universities and the UK partners. But now more towards the real output is that we are already started to embark on the postgraduate capacity building program. And we have already issued a call, which we received applications and already done the reviews, and we're hoping very soon to actually award the 2 selected or successful PhD research students whom we are going to provide research support. And so not necessarily paying for their fees or tuition, but necessarily to enable them to undertake or complete their studies within on NCD area, either at master's or PhD level. We also have what we also calling the scoping studies, which we continue to undertake. And again, we have issued already there's the call for mini grants. And for these 2, we got 2 mini grant winners, and hopefully also this is going to commence very soon. So again, so far, and these are not just going to be within the University of Nairobi, but across the 5 universities and even beyond. So again, it's not just concentrated on the University of Nairobi, but even beyond the University of Nairobi, because we hope that they can benefit from our international linkages and also linkages within African universities, so that then their capacities can be built, and also they can benefit from mentorship across the region. Now, another activity that we have is the capacity building short courses, workshops, and seminars. This, of course, initially in our conception would be a combination of both virtual and face-to-face. So far, face-to-face has been affected by COVID-19, and today I would say we are very fortunate. The College of Health Sciences has been able to support us to learn our first webinar, which is virtual. So we are moving now more towards virtual webinars. And we hope to have a series of 6 webinar series jointly with the College of Health Sciences between 2020 and 2021, and even beyond 2021, because we'd like to have a continuous dialogue and engagement, both with academia, the practitioners, the researchers, scholars, and the private sector, and pushing a dialogue on how we move forward with the non-communicable diseases as a continent, as sub-Saharan Africa, and even Kenya in particular. So this is one of first webinar series, but we hope to have regional and continental capacity building short courses, which shall be issuing this shortly. Once again, we conclude with our partner universities, so you will continue to provide this information on our website, and we'll be happy even young scholars and researchers can make applications for the short courses, and even seasoned researchers can also participate in these short courses. So we'll keep providing this information on our website, and we hope that across Africa, sub-Saharan Africa, and even Africa and beyond, individuals will participate in this series. Now, we also intend to have student and staff exchanges, that is within the partner universities and even in the non-research intensive universities within the sub-Saharan African region and Africa at large. And this will entail short visits. And our plan was that students, for example, could spend time in other partner universities, Makerere, Wits, Ibadan, or Ghana, and even in the UK universities. However, again, because of the short COVID-19 situation, we are unable to do face-to-face at the moment or to even facilitate travel. But we are also exploring how best we can achieve the same goal. Of course, we cannot have the physical visits, but again, with this postgraduate program, it will also enable us to also explore what possibilities we have even within the African region. Is it possible? How much can we do with this, especially coming 2021? And our emphasis, like I mentioned already, is on early career researchers. So we really would like to engage more with the young students, postgraduate students, and those interested in NCD research and studies. Also, this, of course, we should provide them opportunities to develop strong research relationships beyond Kenya, beyond Uganda, beyond South Africa, beyond Nigeria, beyond Ghana, and also have student mentorships. Then also we hope that they can be able to gain access to facilities and infrastructure in other African universities and even those in the UK, because some of the maybe analysis equipment and methodologies that we need are not available in Kenya. So we do hope that we can be able to access this through this network. Now, so as a center, we continue to write proposals and expand our collaboration networks. And this we are doing very actively. So at the moment, we are even responding to the NIHR call, if you're able to see the UKRI website. And many other calls we're responding to. Some, of course, we do hope that it's successful, but this is really a core mandate of the center. So again, and because of this, like I mentioned earlier, this is one way of expanding our network, expanding our collaborations. So we'd be quite happy again for those interested to even partner with us in writing proposal grants, to really join us, not just within Kenya, but even beyond Kenya. So that then it's Africa-wide. It's also with our joint UK partners, quite a number of them are members of the what we call the UKRI 8 partner universities. So again, we hope that we can partner with more than what we already have. So again, this is just for you to know. Now, we as an annual event, we hope to have annual international NCD symposium focusing on NCDs. And here our aim is to enable NCD researchers of international repute, promising research students, private sector, industry, policy, and academia to come together and discuss NCD health issues of relevance to Africa. And this again would also provide the participants with an opportunity to interact with universities outside of Africa, to interact with African governments and industry and NGOs, and even research institutes. We had hoped this year would have our first symposium was to be in Kampala in April 2020, but unfortunately, due to the COVID-19 and logistical reasons, it didn't take off. And because of this, partly we've also been able to support more than what could have supported in terms of the postgraduate support program. So this is how we've been able to use part of the support that could have provided for this symposium. And also then we hope that then we'll be able to support more participants coming 2021. So we are looking forward to our next symposium in April 2021. We will again announce this on our website, the date and the venue of the symposium. And we do hope that then the COVID-19 situation will have improved so that then we can be able to move or travel across internationally. But then if it doesn't work, we'll have then to explore what possible alternatives are there, whether we're going to go virtual or what will happen. So again, please, we hope that you can engage. Yes, nearly, yes.
Yeah.
How many minutes, Shar, can I take?
-1.
-1, okay, fine, that's good. So again, this other one is already like repeated, now that I'm -1. We hope to expand our network beyond ourselves. Already I mentioned into the less research intensive universities. We will reach out to research institutes, but also can reach out to us. And also we hope to engage with partners, especially government and other agencies that are involved in NCD work. Just for your information, our center also has a team, international team of advisory board members in Kenya, Australia, South Africa, Nigeria, Ghana, Amsterdam, and also within Kenya. So that includes also the ARUA Secretariat in Ghana and South Africa, and also UKRI. So these are just our partners, again, who will also play a key role. And these are really internationally renowned experts in the area of NCD. So I think that is just that. This is just a Kenyan framework. We are just ourselves. I think I don't need to go into this. But again, we also continue to expand the Nairobi University members. So again, thank you, Richard. This is just to just acknowledge our partners again.
Thank you very much, Dr. Ann Kamau, Director of the ACE NCD based at University of Nairobi, and we're sure that many good things are going to happen. We'll hold any questions. I hope Professor C.F. Otieno is ready now, and we'll have to just shorten. I'll beg your indulgence, audience, for a few minutes. Prof. Otieno, are you ready?
You able to put the slides?
Yep, I think so, yeah. Prof. And as he's doing that, if you have any comments or questions about the ARUA Center of Excellence, please post them on the chat. Okay, so we don't seem to be able to get Professor Otieno on. So what we will do is that, as we've said, we're going to have a series of webinars. So perhaps we will get him on next time. What I'd like to do now is just, we have a few minutes, we can just have, there were a couple of questions that we had left to the end. So I'll just call back Professor Nzioka. There was a couple of questions. One of them was about the whole point about the hoax, COVID-19 being a hoax and the impact of the social factor. Maybe you can just comment on that, and then we will.
And, this is Professor Nzola again. Eh?
Yes.
Yeah, just to come back and tell and and say that I was not satisfied with the comment Professor Nzioka said about risk communication. What I want to hear is really concrete communication of how we are going to communicate risk so that people understand that COVID is real. But what Professor Nzioka said, he was neither here nor there. So I want to indulge Professor Nzioka again to come up and be very specific.
Yeah, how do we get the point across so that it's not the police
exactly.
You carry your mask and you put it on properly.
Exactly. Those, and then because we are struggling with that aspect, how do we communicate risk? So, Prof. Nzioka, I know you know what I'm getting at. So please let us dialogue.
So, Prof. Anzala, what you're saying is that why is it that we fear not burying our people properly compared to staying alive with a mask?
Exactly.
Yes, those comparisons. Prof. Nzioka, floor is yours. And unmute.
Thank you very much, Professor Anzala, for your question and persistence. I think we all grapple with those kind of difficulties. As I told you before we joined this meeting, I was sent a small text, and it was asking, tutashikwa na corona or tutashikwa na polisi? Those who probably do not know Kiswahili, it's a Kiswahili translation of, are we going to fear the police or are we going to fear COVID? To me, risk is anchored on one's position vis-a-vis the risk. And I just gave you an example. I told you, if you told people in a rational way, which is the model we normally use in health education, that there is a risk there, people then should avoid risk by doing what is logical. The stimulus response, the theory of reasoned action, and that kind of thing. But I think we need to move out of that, because that is when you are dealing with COVID as a disease. Because COVID as a disease has a way of being perceived from a purely biomedical germ theory of disease. If you touch this, there will be a germ, and therefore you get it. That is a theory, the germ theory of disease. But I think, to my mind, that is the conventional way of prescribing, or premising our interventions. But do all people then perceive that risk, even the learned? Because the problem is, even the learned, do they still see it as a risk? And that becomes very interesting. I'll tell you, let me, before I get into the COVID, let me give you an example. I have done some bit work of on HIV and transmission. And it is my finding that it is not even education that matters. People will start by saying that is the daughter of the priest, and therefore she's good and clean. That is a school girl, and therefore she's nice and whatever. And therefore, to that extent, I'm secure. So people anchor. The point I'm making is, you can see a movement from logical, scientific approach to the theory germ of a disease to another socially constructed perception that one anchors their safety, because that is a schoolgirl in school uniform. She's safe, and therefore I can have a protected sex. In the same way, that is a member of the Christian Union and therefore must be clean. that is a plump woman, therefore big, and therefore she cannot be controlled because HIV is meant for thin and skeleton looking, you know, those kind of arguments. They are neither here nor there. And therefore, to my mind, you must anchor risk perception on the ways in which lay persons blend biomedical knowledge with their limited understanding, their limited knowledge, their knowledge that limits understanding, if you want to put it in a better way, to their knowledge that limits understanding, in constructing some form of safety and therefore risk aversion. You know, you avoid by doing certain things which are socially meaningful to you, but sometimes they do not provide you protection. Now, let's come to COVID. How does it manifest itself? That could be an issue. How would a layman, therefore, who has not been tested, even the person who has also been tested, relate with COVID? Is it the consequences of COVID? Or it is what you perceive to be the consequences? And that's how then we anchor we create our own safety through conceptualization of processes. And therefore, until you get to understand, and that's why I was saying the importance of social sciences, is to be able to understand how the blending of biomedical knowledge and lay perceptions is used in order to generate notions of safety and from risks, then we would not be able to move far. Because as a planner, and I can understand where you are coming from, Professor, you are required by either government or by somebody to institute measures that will then bring change in a particular behavior. But you can only anchor that from the rational belief that if I put in this intervention plus this one, then I get this. But sometimes you put A plus B and you don't get C. I think that's where you are getting a challenge. It is because there is another item
Exactly.
within the equation, and that is what you don't know. And that's where you need the social scientists to be able to unearth that X, so that A plus B
equals C.
Into brackets, question mark equals C.
C, exactly.
Yes, until you uncover that C, that brackets, then you will not be able to get the answer. And at all times, you'll always get it wrong. And that's why I told you, and I gave you an example of even educated people would still find themselves having unprotected sex because they have their own, they have socially constructed who is safe and who is not safe. And therefore, as they anchor that, their safety on that, they are not going to yield. And therefore, they'll contract the virus. Look at ourselves and look at the way we are protecting ourselves as we move around.
Sorry to interrupt. We just need to begin to wrap up.
So let's just look at ourselves and the way we even put on the masks. Sometimes they're just there to be seen, not really because they are protecting us. And it is not about laymen in Kibera or Madare or some slum area. It is even with us. Go to your office and you'll find the same. And people, if they notice they are going to talk to Professor Onzala, you will see them closing their noses, you know, their masks. Once he disappears or faces the other direction, they let the guard, you know, and that's how we are doing it. So it is A plus B into brackets C, something question mark, and then is equal to C. And until you discover what is the question mark, then you will not get the question right. Probably I'm a bit theoretical, but I think that serves as an explanation.
Yeah, thanks for that. There's one comment, Onyango Umo on the chat who wanted to make a comment on risk, and then we wrap up. You're still present?
Thank you very much. Am I on?
Yes, you are.
Yes, thank you very much, Dr. I just wanted to weigh on the communication from Professor Nzioka and Professor Nzala. And I will talk from an anthropologist's point of view and looking at the whole issue of race. I think I can see the difficulties Professor Nzioka has had in trying to understand. That is that it's getting risk. We need to start from a point of risk according to who, for what, and for who. So that is the starting point. And in communicating risk, we need to realize that risk must fit as rightly as Professor Nzioka and making up of everyday life. Something that somebody would loosely call the people's science, quote unquote. So if the scientist wants to tap into the people's science, their explanation of what is going on, which might be right or wrong, but it's what makes sense for them. We must be able to piggyback on existing practices. In other words, risk must make sense in the context of everyday practices. So if we want to communicate risk, we must look at what are the people thinking about what we want to communicate risk about. What do they know already? What they know already might be good or right or good in the sense that it points towards the right direction of prevention or understanding of risk, or it might be completely off. But therein lies where we need to go and piggyback on what they already know and try to make them move in a certain direction. So I think my straight answer is on, if you want to communicate risk, you must be able to piggyback, latch on, just like a parasite latches on something and on what they already know about that thing or what they're already doing about that thing, and then you can change the understanding of risk. I hope that is helpful. Thank you.
Thank you very much. I think that's clarifies things, yeah. I'd like to bring to a close and hand back the host, but before I do that, I'd like to sincerely thank Professor Charles Nzioka, Professor of Sociology, for just opening up that space of the social side of COVID. I think it was very enlightening for many of us in terms of just beginning to understand what we need to do. And also Dr. Anne Kamau, Director of the NCD, the ACE NCD, for just telling us a bit about what the project is doing. We will have some, in the next few weeks, we will have some other webinars around this. The ARUA NCD is multidisciplinary, so we are talking about doing research and building capacity from the social sciences, the bench sciences, up to the clinical areas as well. So you'll be hearing a lot more about the work that is going on, and as Dr. Kamau said, you're all invited to participate and to contribute to what we believe will be a great center that we're trying to build. So I'd like to hand back to
Dr. Aya, before you hand over, I see Prof. CF was able to get sound. You could give him maybe even a minute, even if it's just to say hello. For his
that's fine if he's able to get sound. I wasn't sure that he's able to get sound, and then we can reschedule the talk for a later time. Prof. CF?
It seems it still hasn't worked well. Yeah.
Okay, no, that's no problem. So just some closing remarks from Dr. Anne Kamau. She's also a medical sociologist, so she also has a view about risk. So, and then we can close. Dr. Kamau?
Thank you, Richard. I think for me, when we think about communicating risk, we need to ask ourselves, what did we do initially when we got the COVID-19 situation? Of course, we got into an sort of an emergency mode and created panic among the citizens. So, and everybody now wanted to discover this new disease. And then somehow we relaxed. So it's sort of been moving from red, green, yellow, back now to yellow, and then back to red. So it means that the way we communicate also has to vary with the way the risk that we are faced with. Of course, understanding that we have a continuous risk, and we shouldn't get to a level where we feel comfortable, almost get into yellow towards green, and then back to red. But the question for me would be, and I think this also has been, Onyango has almost said this, is what are we communicating? What messages are we giving to the people? So initially, we were saying, if you get or suspect you have COVID-19, please come to the nearest health facility, we'll check you, you'll get government support. And we saw that happening. But of course, now we move to the community level, and you're saying that now we will recommend more of community level management. And if you get COVID-19, know that it's more of your responsibility, it's not more of a government responsibility. So then for me would be, what incentive would we give to the people to actually even go for testing? And I think this for me is all around this. And of course, this risk is weighed against other risks, socioeconomic risks, the risk of losing a job, of course, the risk of losing income, if like we know that our economy is 80% informal, with only about 20% of our economy being formal. So what support mechanism are we providing to those that we want to avert risk among? So if you're not going to provide solutions for our citizens, then we might see them continue to engage in risky behavior. And this is something that as we package our communication material, what also options are we providing to people? Those who don't have, what options do they have? If they have to go and pay for all the medical care, they might just say, let me die of the risks of COVID-19. And this is maybe what you're witnessing. So again, just to conclude from the NCD, I think I would like to thank all the participants. Our most sincere thanks to the College of Health Sciences for supporting us to do this. And we really look forward to partnership across the University of Nairobi, across other universities in the region, and kindly just reach out to us. Richard, you can share our ACE website with the team. I think already I put it on my presentation. Can reach out to us. For me, I am based at the Institute for Development Studies on the 5th floor of Gadi Wing. And so if you come to IDS, you'll find me there. And Richard is also reachable. Professor Nzioka is on the 4th floor of Gadi Wing, again, main campus. So please reach out to us from where you would go to reach out. We really look forward to meeting you and to engaging with everyone. And it doesn't matter across disciplines, anthropology, sociology, economics, engineering. And I should have acknowledged Professor Mandara Ogot, also, who is a key member of this team, and also who is also with us in addition to CFO TNO. So thank you so much, and we really thank everyone. Thank you.
Thank you very much, Dr. Kamau. I'll hand back to the host, Dr. John Kinuthia, and I thank Kenyatta National Hospital for hosting us. Dr. Kinuthia.
Thank you, Dr. Aya, for facilitating this session very ably, and thank you to all our speakers and all our participants for supporting these webinars. We look forward to hearing more about ARUA in the coming webinars, and from Kenyatta National Hospital, we are ready to support. I don't know whether we can also be invited to be partners, or as a teaching hospital, we are not. We have to go under the umbrella of University of Nairobi. Anyway, that is something for discussion.
It goes without saying.
Yes.
Yeah, just come direct to us. You are the automatic partners. Just come.
All right, thank you so much. So we look forward to partnership. We'll support these initiatives to the best of our ability. You can always you can always count on our support. Thank you to everyone, and we see you next time. And we look forward to hearing from Prof. CF. I know he has really struggled with his device, but I'm sure we'll be able to hear his talk. Thank you.
Thank you very much, and a good day to everyone.
Thank you.
Thank you.